The ABTA is pleased to welcome you back to our webinar series. Our webinar today will discuss why tumor location matters. This webinar is funded in part by Novocure. My name is Vince Rock, Program Manager here at the American Brain Tumor Association, and I'm delighted to introduce our speaker today. Dr. Navid Redjal is Director of Neurosurgical Oncology at the Capitol Health Institute of Neurosciences and Cancer Center. He is a board-certified Harvard-trained neurosurgeon with extensive research and clinical background in neuro-oncology. He has conducted significant translational research in targeted local therapy for brain cancer and has been published in a number of medical journals devoted to neurosurgery and cancer research. He has been involved with the Congress of Neurologic Surgeons Glioma Guidelines Committee and has co-authored treatment guidelines for glioblastoma multiforme and low-grade gliomas. He currently leads the weekly Neuro-Oncology Multidisciplinary Tumor Board at the Capitol Health Cancer Center. Thank you for joining us, Dr. Redjal. You may now begin your presentation.
Thank you, Vince. I appreciate the introduction, and I greatly appreciate the opportunity to give this important talk. I hope everyone is doing well during the COVID crisis and enjoy the talk. The goal of this talk is really to help you guys understand the great importance of why tumor location matters. My goal is not to teach you all the neuroanatomy, but to establish a good framework such that you can understand that tumor location really helps dictate treatment and symptoms. What we'll do is we'll start with establishing a framework, and then we'll move on and we'll talk about specific examples and advances in neuro-oncology. So, kind of start off, I have no disclosures. Move to the first slide. So, why tumor location matters? It helps us explain specific symptoms. The brain is extremely complex and has multiple various functions, and we're learning more and more about it. This is a basic picture on the side here, just showing the different lobes of the brain with a very simplified view of the brain. The specific symptoms, sometimes the tumor will involve the motor pathway, and you'll have weakness of a specific side of the body. Sometimes they'll affect the visual pathway, cause visual disturbance. Speech problems, if it's involving speech centers, and hormone imbalance, and involving pituitary glands. These are just very kind of basic examples, which we'll kind of get more in depth into in the further talks. But definitely, where the tumor is going to help explain the symptoms. And even more importantly, the area of the brain where the tumor is located is an essential point in contributing to treatment. Surgery, radiation, chemotherapy, and targeted therapy are some of the treatment paradigms. And really, the location of the tumor is extremely important in helping us decide these treatment modalities. Not only is it the region or area of the brain the tumor is located, but the specific location of the tumor defined by its origin. What I mean by this, tumors kind of involve the meninges, so they're extraaxial, so this word extraaxial, and then there's tumors that are intricately involved with the brain, and they arise from the brain, such as gliomas and glial cells. And then there's other tumors that go along the cranial nerves, they're like schwannomas, and then there's areas such as the pituitary gland where tumors kind of can arise from there. So the goal of the talk is for you guys to understand that what tumor location is defined as is the region or area of the brain where the tumor is located, and its location by its nature. So using this location in combination with the molecular pathology currently will help determine the best neuro-oncological treatment. And I'll get into the details of what I mean by that. And what is the best neuro-oncological treatment? It's the treatment that maximizes the quality of life and the quantity of life. What I mean by this is the brain is different from other types of tumors in the body where if you have a really bad arm tumor, you can cut off the arm and still have a pretty decent quality of life. In this case, sometimes there's tumors invading into eloquent brain cortex, such that if you cut out the whole tumor, and we don't really take margins in brain tumor surgery, you can really destroy the patient's quality of life. So always the best neuro-oncological treatment will aim to maximize the quality of life and the quantity of life. We'll kind of get back to that throughout the talk. So we've made significant advancements in technology and neuroscience, and this really has helped us understand functional neuroanatomy in combination with amazing cadaveric neuroanatomy research. This is from kind of the Dr. Roton, who has done some amazing work for cadaveric neuroanatomy. He's one of the kind of the Bible of neuroanatomy for neurosurgeons. And here's just a picture, just kind of showing the complexity of like the surface of the brain and all the different gyri, their names and their functions, just so you guys understand the level of complexity of the brain. Not only that, nowadays with advanced neuroimaging, things like functional MRI. So functional MRI measures brain activity by detecting changes associated with blood flow. So basically, the technique relies on increased cerebral blood flow and neuronal activation are coupled when the brain is in use. So this use of functional MRI has helped us really identify and supported, our ability to really understand where certain complex functions of the brain are kind of localized. In addition to that, we now use diffuse tensor imaging and fiber tractography. And what this is, it's a technique where we kind of are able to kind of reconstruct the specific important fiber tracts that are important in the body, and this helps us kind of in surgery and helps us decide on treatment modalities. And even more so, intraoperative mapping, and this is really the gold standard of really assessing function. It allows us wake patients to monitor certain complex functions, and we'll get even into more of how important this has become in really maximizing our ability to treat patients with surgical resection. But in addition to that, awake brain surgery has really added to our ability to localize complex functions such as playing instruments and things like that, and we'll get to that again later in the talk. So I'm going back to this slide. So what we're going to kind of focus on as tumor location is being defined as the region or area of the brain where the tumor is located. For instance, is the tumor located in the posterior frontal lobe involving the motor pathway, or is it involving the visual pathway such as the optic nerve? And then its location by its nature. Is the tumor intraaxial? Is it within the parenchyma, or is it extraaxial? Is it outside of the brain? Is it part of the meninges? In those cases, those tumors push on portions of the brain, and they make that in those cases sometimes those lesions are easily resectable without affecting eloquent function. We'll kind of get back to that concept throughout the talk. So we're going to just start off with an example, and I'm going to use this basic kind of visual pathway to discuss why tumor location matters based on the concept that we just talked about, the region, area of the brain, and the location by its nature. So this is the standard visual pathway. Vision is sent from the eyes through the optic nerves, and it kind of crosses at this place called the optic chiasm. It goes through these optic radiations, through the temporal lobe, and it ends up being processed in the occipital lobe. I'm going to kind of keep coming back to this diagram. So here is a tumor that's in the vision pathway near the optic nerve. Here's the optic nerve, and the location by its origin, it's a glioma. So it's part of the nerve. So again, symptoms would be vision problems in that eye, and treatment, because this tumor is part of the nerve, it's not something where you can separate it out from the nerve like other tumors such as an extraaxial tumor. This tumor is part of the nerve, so it's either if you do surgery, you lose complete vision in that. eye, or you think about doing other things such as radiation and chemotherapy. But this, again, and going back to the concept of why location matters, is the region of the tumor is the optic nerve, part of the optic pathway. The location is intrinsic to the nerve, and it's difficult to resect and push away from the nerve. So that's one example. Moving on, going back to this pathway, I want to talk a little bit about pituitary tumors and how it affects the vision. So again, this area here is where the optic chiasm, optic nerves are, and then here's kind of a picture from Dr. Roton's neuroanatomy dissection, and here is where the optic chiasm, optic nerve is, and here's where the pituitary gland is. Here's kind of a zoomed up view of that, and you can see a tumor in this area can push on the optic chiasm, optic nerve. So these types of tumors, pituitary tumors, they're affecting the visual pathway. They're considered, this area is considered the sella. Areas around are called parasella, and it's affecting the optic nerve and chiasm. Now, location by its origin, it's not invading the nerve. It's extraaxial. It's coming from this kind of pituitary area. So here's an MRI scan of a pituitary tumor pushing up on the optic nerve, the optic chiasm, and because this is not involving the chiasm or nerve, you can do surgery and decompress the nerve and chiasm. So not only that, you can go a little bit more in depth and kind of digress and talk about pituitary tumors. And when you have a tumor in this location, you have to start thinking about other things based on its origin. So certain tumors in the Sellar region are pituitary tumors. So pituitary tumors can be functional tumors, meaning they secrete hormone. The tumors like prolactinomas can cause you to have galactorrhea, amenorrhea. There's tumors that secrete a certain type of hormone called ACTH that can cause Cushing disease. There's growth hormone tumors. There's thyroid secreting tumors. And then there's also non-functioning tumors that are clinically silent and don't secrete hormone. So the reason I'm going to this slide here is, again, if you have a tumor located in the area in the Sellar region near the pituitary gland, it could be one of these tumors, and in the workup for such a tumor, hormones need to be checked. And in particular, one of these tumors, prolactinomas, is actually a tumor that can be treated medically, and it can basically shrink the tumor. So again, this is going back to that concept why tumor location matters. A tumor in this area can cause visual problems. You have to check hormone function, and sometimes based on all that, the treatment is dictated by that. Going back to this area, the Sellar parasellar area. So this area here is kind of considered the Sellar parasellar area. And what this diagram is showing, kind of this in-depth anatomy here, is this area here is full of cranial nerves. There's a lot of nerves that come from the brain and come out of these small holes in the bottom of our skull, such as cranial nerve 2, 3, 4, 5, 6. And tumors in these areas can cause those specific symptoms. And there's a lot of different types of tumors in those areas. But what this picture shows is, again, that area, this is kind of where the pituitary gland sits, and this area on the side is a parasellar area near the cavernous sinus. And there's a lot of different nerves in this area. So if a tumor is compressing the optic nerve, it could cause visual field loss. If a tumor is pushing on the nerves that control eye movement, the third and fourth nerve, and the sixth nerve, it could cause diplopia or difficulty with eye movements. And not only that, tumors in this area can cause facial numbness or facial pain because the trigeminal nerve divisions are here also. So again, this is pointing out that tumors in the Sellar/parasellar area, as they grow up, it can cause issues with the optic pathway. But given their location, you also need to be aware that they could cause other cranial nerve disturbances. So this is, again, one of the areas that can cause a number of different symptoms, and the treatment, again, is based on the involvement of possibly the pituitary gland, involvement of this cavernous sinus, this big vein here where all these nerves are, and that will kind of dictate treatment. Moving on in this pathway, so now we've talked about the optic nerve, the optic chiasm, and as we move back, there's these optic radiations. So this area is the temporal lobe, so a tumor in this area can affect vision. So with our advanced imaging and technology, we can use diffuse tensor imaging to do fiber tractography to identify the location of the optic radiations in relationship to the tumor. So here's a picture here of an intraaxial tumor that's most consistent with the glioma. And the question is, can you take all this tumor out without affecting the vision? And so you have to be aware that a temporal glioma that's kind of extending medially can affect vision. So they did 3D tractography. This is kind of flipped here from the imaging, but basically they identified the tract to being in this area. And so we utilize that information to resect the tumor, preventing any visual issues. And also, prior to surgery, in understanding the symptomology, you have to be aware that the optic tracts are in this area. Does the patient have vision issues prior to surgery, and to really assess it after surgery. So here, the tumor is temporal lobe and evolved to optic radiations as it goes back, and the origin of the tumor is intraaxial. This is not a meningioma that's pushing on the brain. This could be infiltrated into the tracts, and in that case, we really want to be aggressive and involve and take so much tumor out that you also take out the vision tracts and cause blindness. Further moving back, so here's the optic radiations, and we're moving back to the occipital lobe. The occipital is where the primary visual areas are. And here, using functional MRI, so you're checking the activity of the patient's cortex with using functional MRI while their vision is stimulated, they basically saw that these areas kind of were highlighted. This lesion here has a consistency of most commonly a glioma, so it's intraaxial glial in nature. So prior to undergoing surgery, they assessed the function of the vision and kind of identified that via the functional MRI that the visual cortex was pretty close to the tumor. So if you wanted to be aggressive with resection, especially in this area here, there's a potential to affect vision. Vision is one of those things that is difficult to assess in a sleep patient. So some people have actually started to do awake surgery where they assess a patient's vision. So in this case, the patient has basically something to check his vision while they're stimulating that area in order to check if he has any visual difficulty during the surgery in terms of resection. This is not common, but this was a paper that they talked about doing this. And again, this goes back to kind of functional neurosurgery. So here's some more simple examples. We kind of went through vision pathway, but real quickly, hearing. So hearing is involving the ear. Information is transferred to the cochlea, and it goes from the vestibular cochlear nerve into the brain through the auditory pathway. So one of the most common tumors is a vestibular schwannoma. So again, the region of area is the auditory pathway along the vestibular cochlear nerve. So here's just an example of someone who had a tumor along the nerve that was really small, affecting their hearing. This tumor is considered extraaxial. It's not within the brain parenchyma, but it's actually intimately involved with the nerve. It rises along the Schwann cells. And these tumors can grow, and so usually they're monitored. Here's another patient who had a very small, tiny little tumor in the left-sided nerve, and then following over a couple of years, it didn't change in size. But a tumor like that this is intimately involving the nerve, can explain our symptoms, which is usually hearing and also sometimes vestibular symptoms. As the tumors get really big, they can start pushing on the brainstem in this case, and we'll talk about how that can cause other symptoms also. But again, this is along the vestibular cochlear nerve, and it's arriving from the Schwann cells that are intricately associated with the hearing nerve. Another example here is smell. So smell sensation occurs and goes through the olfactory nerve to the olfactory bulb, and here's an example of a large tumor that's extraaxial in nature. It's a meningioma that basically caused the patient to have loss of smell. And also, we'll talk about what also this would cause in more complex functions, but this tumor is along the olfactory nerve, anterior skull base, and this patient basically came in with years of not having smell, and then over time it caused increased swelling and caused seizures, and that's how she actually presented. Interesting, patients who lose smell, it's not a red flag for them that it's a tumor, and sometimes patients just think it'll come back. But this tumor, again, is not part of the brain parenchyma. It's extra-axial in nature, so you could take this tumor out without affecting significant brain parenchyma, and that's what we did. One might ask, all this prefrontal cortex, what else does it affect? So again, you learn a lot from sometimes injury to the brain of what that brain function is. So a famous story is of Phineas Gage. So some of these higher order neurologic functions, it's not like, oh, you're weaker on your arm and it's noticeable. These are things like personality changes and changes in distribution. So Phineas Gage, this picture I'm showing you is he's a famous story of it in the 1800s. He was the American Railroad construction foreman, and he had this accident where this iron rod basically went completely through his head, destroying much of his frontal lobes, and he had profound changes in his personality. And these types of injuries help us understand function also. So he is a famous quote where he was considered no longer Gage, and here's a nice quote talking about how he used to be regarded as the most efficient and capable foreman, but then there was a significant change in his mind. He became irreverent, indulging at times in the grossest profanity, manifesting real deference for his fellows. He was quoted as a child in his intellectual capacity and manifestations. He has the animal passions of a strong mind. In his mind, he was radically changed, so decidedly that his friends and acquaintances said he was no longer Gage. So other than kind of sensory functions and things like that, motor functions, there's certain parts of the cortex that have higher order neurologic functions, such as controlling personality and things like that. And in this case here, this is an example of how an injury helps us learn more about the function of part of the cortex. So moving on to motor and sensory pathways, this is kind of a simple picture of what is considered the primary motor cortex in green and the primary somatosensory cortex, the sensory cortex. So this is the posterior frontal lobe, and this is kind of the anterior aspect of the parietal lobe. So this cortex has a somatotopic representation. So this is the bottom of that gyrus, and this is kind of the medial aspect. So going back to this picture, so here is face, tongue, and here is kind of the leg, hip area. So when you look at this cortex here, so this area would be kind of face, tongue, and this top area starts to be leg. So if you have a tumor in this area, it's going to affect mostly the face, tongue, and this area here would be the leg area. For motor and sensory is the same. So the gyri are basically somatotopically oriented. So then this information here is sent down through the brain, through the axons, and goes through the brainstem, and goes down through the brainstem and goes down to the spinal cord. So this is just kind of, again, I don't want to teach all the neuroanatomy, but this is basically a simplified view of, kind of the pathway that controls motor and sensory function. So just to the side, the brainstem is where all these information from the higher cortex goes down through this kind of small 2-centimeter diameter cable that sends information to the rest of the body. And just to understand, there are a lot of different tracts and nerves and things like that are going through the brainstem. It's a very, very small area. And again, going back to why location matters is if you have a small tumor in the middle of the brain here, surgery is definitely has high risk because it can affect a lot of these different tracts that are going through this small 2-centimeter cable. So here's an example of a tumor within the brainstem. There's also a little other tumor in the cerebellum. So this is right smack in the middle of the brainstem. And the location and this tumor, this patient actually had some history of metastatic cancer. He had more than 2 lesions. He never got biopsy, but the assumption was, given his history of metastatic cancer, these lesions were consistent with metastatic cancer. So metastatic cancer, because we know that's the type of tumor, it's not a glioma, is very sensitive to stereotactic radiosurgery. So this patient actually underwent stereotactic radiosurgery and did really well. You could see that if we had to go through a surgery for something like this, it could result in extensive morbidity again. So the region of the tumor is in the brainstem and location by origin intraaxial, but it's a metastatic tumor, so that changes the treatment. Going back to the motor pathway, so this is the primary motor cortex is sending information down, and this area here is the internal capsule, and it goes through the cerebral peduncle. So if you have a tumor in the temporal-parietal area, so this area here, we use diffuse tensor imaging to identify the location of the tracts in relationship to the tumor. Sometimes these tumors, this tumor has an appearance of an intraaxial tumor, such as a glioma. So it's not a meningioma that's pushing the brain. It could be actually infiltrating the brain. So sometimes we use diffuse tensor imaging in order to identify if this tract is being infiltrated by the tumor or it's being deformed. The tumor, when it is being deformed, we can attempt to resect the tumor, but we have advanced our ability to detect in combination with diffuse tensor imaging the activity of the tract. So one thing that we've started to do as neurosurgeon is we do intraoperative direct subcortical stimulation. So in the surgery, as we start getting to kind of this area here, we start stimulating to see if it affects this tract. And here is a kind of a representation from this paper here where you take this probe and you stimulate the tract. So here's our resection cavity, and we have a probe which is navigated, and we think the tract is here. So we know there's a little bit tumor here, so we keep resecting tumor as we stimulate. As long as it doesn't affect motor function, then we're able to keep taking the tumor. Once it starts affecting motor function is when we stop. Utilizing intraoperative, utilizing advanced neuroimaging like diffuse tensor imaging in combination with neuronavigation, in addition to using subcortical stimulation, we're able to maximize resection for an intraaxial brain tumor such as the glioma. And here's just a kind of a picture. Here's the tract. Here's the direct stimulation to that area to assess if there's any changes in motor function. And here in the OR, we use neuromonitoring to assess if we see movement in the patient's arm or leg when we stimulate. If we see that, then that's an indication that this could be potentially, the tumor could be potentially involving that tract, and then we stop. But if we don't, then we're able to get maximum resection. Continuing on, so remember from the picture, the motor cortex is here, and here is a posterior frontal brain tumor that we could be involving the motor cortex. So intraoperatively, in this tumor, it looks like a glioma. It's primarily part of the brain. It's intraaxial, so sometimes these tumors infiltrate the brain. Unlike a meningioma or extraaxial tumor, which is separate from the brain parenchyma, these can actually infiltrate the motor area. So here is a picture where they use neuronavigation to identify that the motor tract seems to be medial to the tumor. Intraoperatively, you stimulate the cortex, where you're going to resect to minimize, to make sure you're not affecting motor function. And if you're not, then you can be able to get a complete resection of that site. So moving on to more complex functions like speech. So speech in the past, we had this kind of concept that there's a area for speech production, which is called the Broca's area, and here's just a couple of different depictions of what that's thought. Broca's area, which is for speech production, is thought to be in the inferior posterior frontal gyrus area, and then there's a concept of speech comprehension being experienced in the Wernicke's area, which is the posterior superior temporal lobe area here. But with more and more intraoperative mapping, we've learned that, and as we more and more understand the complexity of speech, this is not necessarily, this is a very simplified view. So, here's just an example of, you have multiple areas of the brain that are responsible for different functions of speech. And even more so, there was a great paper back, I think it was in late 2000s by the New England Journal, where they looked at language mapping for glioma resection, and what they identified is, it's the craniotomies tailored to limit cortical exposure without localization of positive sites allow us to be more aggressive. So the concept is speech is so complex that it's not important to positively map it. If it doesn't affect speech, then you should be able to resect it. Here was when they actually tried to positively map speech for the productive speech Broca's area. This is the areas that all kind of were positive. So if you just made the expectation that Broca's was in the posterior inferior frontal lobe, and you resected a patient who had a tumor here, then you could have affected significant speech function. So this basically showed that concept that Broca's area is only the back of the inferior frontal lobe posteriorly is not true. And here again, in speech comprehension, when they looked at the ability to name objects, so they identified anomia, the inability to name objects when they stimulated these areas of the cortex. And you can see it's just not the superior, posterior, superior temporal lobe. So the concept here is that speech mapping for tumors that are located in potentially a speech area require an awake craniotomy to avoid any type of dysfunction. Even more so they've done intraoperative mapping of patients who are multilingual. So this was a paper that they looked at specifically in mapping an awake patient who knew of over 4 different languages. When they kind of positively mapped language, they found that he had different locations of where his Italian ability to speak language, German, English, French, and which is really important in bilingual, multilingual patients, is to be able to test those different functions because they could be different locations. And so again, this is just going back to how important intraoperative mapping is. And also, there's even more complex functions, such as the ability to play a violin. So here's a video from Europe, where this patient, who was a violinist, was undergoing awake brain surgery, and to her, the most important part of her quality of life was the ability to play the violin. So while the surgeons are operating here, she's playing the violin, and they're stimulating different parts of her brain in order to assess if she is unable to play the violin. So again, going back to that concept that when we do tumor surgery, it's extremely important to maximize quality of life. So if someone's speech is extremely important to them, their ability to walk, their ability to see, their ability to play the violin, and these things need to be mapped, especially if there's any potential for a deficit if you're aggressive with resection, especially in the setting of an intraaxial tumor such as a glioma that could be infiltrated. So basically, kind of went through a lot of information, but my goal with the talk was really to understand how you define tumor location. So the region or area of the brain where the tumor is located, in combination by its location, by its nature, being intraaxial or extraaxial, can help us really understand symptoms and, more importantly, contribute to specific decisions for the best neurological treatment. Again, I define that as maximizing not only the quantity, but also the quality of life. Again, going back to this concept that the location by its nature is extremely important. For instance, an infiltrating glioma that's infiltrating in, for instance, the motor area, it's going to be very difficult to resect without significant morbidity compared to a meningioma that's pushing on the motor strip, which is considered extraaxial. And also what's really important is that we have very, very significant advances in our technology and in our understanding via our colleagues who are doing neuroscience research that minimize dysfunction based on the ability to treat without diminishing quality of life. So functional MRI, diffuse tensor imaging, intraoperative neuromonitoring, and mapping are definite tools that we can use, especially in tumors in the eloquent cortex. And you know, in my own practice, I've moved more and more to doing awake brain surgery, really to maximize function. Because as we learn more and more about the brain, really there's no area of the brain that you can consider to be something that you don't need. So I think as time moves on, we will have more, we'll have continued understanding of the brain, and I think that will lead to more intraoperative mapping and neuromonitoring for surgery. Additionally, you know, we have made really significant advancements in stereotactic radiosurgery and targeted therapy, and these all can be used to kind of minimize morbidity based on the best treatment option. So thank you very much for listening to the talk. Vince, take over. Thank you, guys. And if there's any questions, I'm happy to answer any.
Thank you very much, Dr. Redjal. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. We'll answer questions as time allows. Dr. Redjal, my first question to you, you mentioned some of these techniques that can help people have better quality of life, like mapping and awake craniotomy. How do these techniques help to reduce both short-term and long-term side effects?
That's a great question. So short-term, you know, so intraoperative mapping really minimizes the morbidity based on the eloquent cortex that you're dealing with. So for instance, if you have a tumor that's either close to the motor area, and if you're doing mapping or the patient's awake and you're doing mapping, you can minimize the potential morbidity from potential postoperative weakness by making sure that you're not affecting the cortex that's responsible for motor function. And in terms of, and that's the short term. Postoperatively, I always note that patients who I do wake surgery in and we're mapping, we're really able to maximize their ability to go home the following day, because we know intraoperatively that they don't lose any type of significant function. And then long term, I think on the contrary is, you know, sometimes especially in surgery, we have these preconceived notions that, you know, the speech area is here, the motor cortex is here, and without intraoperative mapping, sometimes we are less aggressive during surgical resection. So there's a lot of data now that doing intraoperative mapping, especially in areas that potentially are involving speech. In the past, we were probably a little bit more hesitant to be aggressive with resection, but if you have a patient that's awake and you're doing negative mapping specifically, you could be aggressive in resection, and especially for gliomas, extensive resection is associated with much better outcomes. The more you resect, the patients have longer survival and better progression-free survival.
Thank you. How does a physician know whether someone is a candidate for techniques like brain mapping or awake craniotomy?
So again, you know, this is why I'm important to give this talk. You know, so there's the reason, you know, tumor location matters is there's a lot of areas of the brain, especially as a patient, if you see a physician and your presentation is with weakness of an arm or speech difficulty or visual issues and things like that, that the physician who you're working with, you know, usually in order to maximize best treatment will be using kind of advanced neuroimaging techniques, and surgically they would also do monitoring in order to minimize deficits. So, you know, I hope the talk has kind of given the listeners an understanding that if they are having these types of deficits, that there's a potential that it's involving these kind of eloquent areas of the brain, and the physician who they're going to be seeing should really, when they see them, should really rely on mapping and neuromonitoring in order to minimize any deficits and to understand really if it is a infiltrating tumor. Are they willing to have those deficits? You know, I've had patients who would like me to resect tumor, and they're okay with being a little blind as long as I'm aggressive. But what I always, and why I'm giving this talk, what's the most important thing is to have an informed patient to understand the potential risks. And like the video I showed you guys of the woman playing the violin, for her quality of life was her ability to play the violin, and that was extremely important to her. So these types of things really, you know, kind of complex functions like that really require violin playing, definitely awake mapping, and other types of things like motor or sensory. You definitely can do sleep mapping, but those are necessary in order to really minimize any.
Thank you. We had another question about function changing in the brain over time in relation to location. So for example, can function in the brain change over time to other locations? So say for example, speech or movement, if that part of the brain were to be damaged, could the location of that function be changed over time?
That's a great question. So you know, there's been some good data that yes, it can. So we've had some younger patients who've had reportedly gliomas in the speech area, so they'll undergo awake craniotomy, they'll undergo partial resection because during the surgery it'll affect their speech. And there's definitely reports that these patients have been able to remap their speech elsewhere and they undergo re-resection. So that concept that does the brain have the ability to, is it considered plastic and can it change? A lot of data is showing that yes, it can, especially for, you know, slower growing lesions. I think for a more aggressive lesion, for instance, like glioblastoma, I don't think the brain usually has that time to change, but you know, there definitely has been cases. But for gliomas, you know, slower growing, lower grade gliomas, there's definitely data showing that the brain has that ability to kind of be plastic and change. And you know, and just from some of the brain trauma data that we've seen and research we've seen, you know, patients who've had catastrophic brain injuries, especially when they're younger, the brain is able to definitely reorganize. So that's definitely a great question, and I think more and more research is going into that. You know, there's actually some research going into some ability in neuroplasticity using transcranial magnetic stimulation with ability to kind of change function in a certain area of the brain. And these are kind of all research things that are being done, but it's definitely an area that's hot and people are really excited to see that ability change in the brain.
Yeah, thank you. We had a question come in about some other parts of the brain that are a little harder to treat or to perform surgery on. Could you speak a little bit about the part of the brain, like the posterior fossa area, like cerebellum, brainstem? What functions are commonly seen there, and what kind of treatment approaches are used for those areas that are tougher to operate on?
Also a great question. So I actually showed a picture of the brainstem, a lesion deep in the brainstem. One of the ways that, you know, we made significant advances in deep lesions is the field of stereotactic radiosurgery, where we can kind of give focal high doses of radiation, parts deep within the brain without causing minimal radiation to the rest of the brain. That's kind of the concept of stereotactic radiosurgery. areas like the cerebellum, we're able to take those tumors out surgically without too much significant morbidity because the cerebellum has some redundancy and is involved in kind of balance and things like that. But deep tumors in the brainstem and definitely have the ability to treat those with stereotactic radiosurgery have really changed. Not only that, a lot of these advances in targeted therapies for tumors, especially in the field of metastatic cancer to the brain, we've seen some amazing responses to specific targeted therapies. So again, going back to if you have a tumor in a very difficult location to get to that can cause significant morbidity, always important that you kind of basically have a kind of multidisciplinary team to assess the best way to control the tumor, but also minimize morbidity from an aggressive surgical approach. Now, a lot of tumors, given advances in our technology, our neuronavigation, we're able to find corridors to get into the tumors without causing significant morbidity. So there's been a lot of advances in surgery also. So I think really with those types of tumor, multidisciplinary approach is probably the most important thing to minimize any.
Thank you. We have time for just two more questions. The first one is there any relationship between tumor location and tumor recurrence that you're aware of?
Yeah, so that's a great question. So it's not necessarily, I would say, recurrence, but certain tumors located in eloquent cortex cannot be surgically resected without significant morbidity. So if your tumor is infiltrating into your speech area, your surgery, in order to minimize dysfunction, would likely be a partial resection, or not as aggressive, not to cause significant morbidity. So in those cases, there's good data showing that the more tumor you leave, the higher rate of recurrence. So if you try to get the gross total, the enhancing disease out, the likelihood of recurrence is less. But if you leave a partial amount of tumor in there, the likelihood of recurrence is more, even if you have adjuvant treatments like radiation or therapy. So in that sense, I would say yes, but based on the amount of tumor that's potentially left behind. I think, sometimes for patients, they'll see a surgeon, they'll say, we'll get all the tumor out, and in an eloquent area without, mapping, usually, they say they got it all out, it's probably not all out, and, you see recurrence happen more in those areas. But I don't think there's any specific location that necessarily means you're going to have more tumor coming out. There's tumors that can invade into the fluid-filled spaces in the brain, the ventricles, and those can lead to seeding of the cerebrospinal fluid, and that definitely leads to more early recurrence. That's one case where I would say yes. All right.
Thank you very much. And our last question for the day that we have time for, you discussed a lot of really great advanced techniques for treating patients and making sure they have the best possible outcomes after treatment. Are these techniques, like the imaging and awake craniotomy and mapping, are these available in community medical centers, or are they limited only to the larger health systems and teaching hospitals?
So that's also a great question. So it's actually, some advanced teaching hospitals don't have it. Some community hospitals do have it. So I think the key is you have to go to a center that's focused, if it's focused on neuro-oncology, they have a center of excellence, and they have that capability of doing these types of things, which are, at this point, I would say, not required, but, the field is moving more and more towards really providing the best type of multidisciplinary care, and some of these things, in order to provide the best outcome, you really do need to have at your center. So I think some community centers who have a significant investment in their center, being really a center of excellence for neuro-oncology, they will definitely have it. And there are some centers or some universities who really haven't made that investment in it So I would say that, really it's extremely important to investigate whichever center you're going to make sure that they have those capabilities. And really, that multidisciplinary approach is extremely important to provide the best treatments. Again, I'm going to kind of go back to and that best treatment is really to maximize your quality and quantity of life.
Thank you. Well, that is all the time we have today for questions. We'd like to thank all our participants for joining us. And thank you once again, Dr. Redjal, for your wonderful webinar presentation.
Sure, thank you.
We'd also like to thank Novocure for their generous support in this webinar. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA programs, events, and services, please visit our website at abta.org, or you can email us at info@abta.org. We could also be reached by phone at 800-886-2282. We're going to pause now for just a moment to conclude our webinar and to prepare for some announcements, so please hold.